People come to us from all over the world with this for treatment because we treat it differently. A lot of centers will say, well, let's wait and see. Let's support them how they are. And they look the worst at birth that they're going to look. However, I've been to the conferences multiple years in a row, and what we see at our center ends up being different than what they would have been. Like literally the trajectory of their life is changed by what they go through at our center, and they become much more mobile. We don't know that they're all going to walk, and we don't know that they're all going to have independent ambulatory mobility. We're not promising that, but goodness, let's at least get them to a position where they can sit in a chair and not be in like a bucket. Because I've gone to the conferences and see them, they're like in buckets and sip and puff wheelchairs because nothing moves. So, here are some of the presentations. Sometimes you have bilateral deflection contractures and Aquinas or club feet. Sometimes you have knee extension contractures. The hips tend to be dislocated, and the ones that have extension contractures, you can see that this child is hyperextended here, and she has bilateral clubfoot. You can see that this one is a clubfoot with an extension contracture. This one is an extension contracture with the vertical talus. So these are entirely different presentations. You can see that this hand is flexed and ulnarly deviated. No, ulnarly deviated. This one is flexed. That elbow is extended. You can see the different presentations. And what is crazy is these just came off the internet. These are not our patients. These were just on the internet. But we've had patients come that present with these same presentations. I will tell you almost always if there's a vertical talus, there's some gene malformation. Almost. Again, there's never an always and there's never an ever. And if they've got one and one, like one clubfoot, one vertical talus, almost always there's a genetic issue there. So, interventions. How do you treat it? Physical therapy, occupational therapy, early and often. Stretching. I can't say that enough. Stretching and movement. Okay. Prolonged stretching is serial casting. So you get them to the best aligned position, whether you're casting the knee or whether you're casting the foot or whether you're casting both, and then you leave it on. With these kids, we do not leave the serial cast on more than 4 to 5 days because they tend to get very stiff. So if we're doing Ponseti casting, which we'll go into in a minute, if we're doing clubfoot casting on these kids, we do not leave that cast on for a week, like we would with a child with idiopathic clubfoot. Because those kids are normal except their feet. We just need to fix their feet. These kids, nothing is normal. And they get stiff very, very quickly. So, at our center, after casting many of these kids and observing their contractions are progressing while their feet are getting better, their knees are getting stiffer, I decided that we're going to go twice a week, okay? And then we're doing an hour of stretching in between. So they don't get as stiff and you're able to correct things better. Okay, so serial casting, bracing, you can either do serial bracing for upper extremities, or you can do serial casting. Once you've corrected things, you need to brace them and correct or hold the position of correction. Sometimes soft tissue releases, hemiepiphysiodesis, there's that word again, neurolysis and nerve decompressions, because if that nerve gets tethered with soft tissue, it doesn't work. And here's the very interesting thing that we're finding at our center is a lot of these kids have tethered spinal cords. So we started doing MRIs in these kids a few years ago and started identifying this. They may not have met all the criteria for detethering, and a lot of the local neurosurgeons weren't interested in doing it because they didn't meet every criteria. but we had a neurosurgeon in Orlando, Dr. Kivan Isadi, who had done quite a few of our detetherings. And he said, you guys are absolutely right. When I get in there, it's like a guitar string. And when he would detether them, then we would notice that there would be some improvement in function, whether it was their feet would be less stiff, or whether they would start to move their feet, or whether they would gain bowel and bladder, or whether they would gain better sensation. So a lot of those kids started improving with detethering. It's not to say that that's an end-all fix-it, right? But so what we observed and what he observed was so powerful that we brought him on at our center now. He's part of our surgical team. And we're doing, on all of our kids with arthrogryposis, we're doing an MRI to determine if they have signs of tethering. And if they do, we're detethering early. And that's one of the really great advantages of being a center, being a hub, right? Because I see more cases, we see more cases than other centers are gonna see. If you see 6 or 7 cases in your lifetime, you're not going to be able to make those distinctions. You're not going to see all the patterns of arthrogryposis. But when you see it day in, day out, and all sorts of presentations, you can come up with new treatments. So, you can do osteotomies. You can do flexion osteotomies, varus osteotomies, whatever deformity is there that needs to be corrected. But that's further down the road. You don't do that on infants. You do that later when they're older. And then also there's a surgery. So when soft tissue is really tight and that knee is stuck in flexion or stuck in hyperextension, you can release all those soft tissues, but you've still got a nerve crossing that joint, right? And if that nerve is on great stretch, when you straighten that knee and it creates pain and creates dysfunction, what can you do? You can shorten the femur and help slack the nerve, and you also don't have to do as aggressive soft tissue release at that point. So that's an interesting way to look at it. So we elongate or we lengthen bones, but we also shorten bones. So it's just a different paradigm to look at something. If you, and I've worked with cerebral palsy for many years before I came into this, if they do a ton of soft tissue releases, but the nerve is tethered, it's not going to be very successful because it's painful. And it just creates more spasticity. It can, which creates a whole cycle. So, even with kids with cerebral palsy that have really bad contractures, we may end up shortening their femur. That's a different paradigm. All right. So physical therapy is essential. Early intervention is essential. Stretching, strengthening. So you must have passive movement of a joint before you can have active movement. Does that make sense? If you cannot move that joint past 90 degrees of flexion, so they're stuck with a flexion contracture at 90 degrees, if I can't move it past 90 degrees, okay, they can't. And their muscles can't develop. And one of the theories as to why these kids develop this is either low amniotic fluid in utero, and they're not moving in utero. Is it chicken or egg? What came first? The contracture, the muscle weakness, or the contracture? I don't know. But let's treat both. Let's unlock them, and simultaneously, let's stimulate those muscles. So we are doing the serocasting, stretching, surgeries when they're old enough, but the first 18 months of life, it is physical and occupational therapy. We have multiple families that move to our area from all over the world for our therapy interventions. And we're also doing electrical stimulation really early on these babies. And we're also doing a form of electrical stimulation called spinal electrical stimulation. So there's superficial electrodes over the spine, and distally, the proximal electrodes, distally, electrodes are going to whatever muscle group we want to target. But it's going through the central nervous system. That was a huge paradigm shift for me about 3 years ago. And I saw it used first on a child with spina bifida. And as I watched it, bells and whistles were going off in my head because I'm thinking, these kids have tethered spinal cords. These kids can't move. If we unlock them, and we've been using peripheral electrical stimulation for a really long time. But when I saw this therapist, it was by happenstance that I did. I was at a different seminar, and the woman, Gertie Mudavali, was there, and another really great leader who's also an adjunct here, Mary Pingelli, was there and said, hey, come, we're gonna treat this child with spina bifida. She's got this new technique. And so I was able to go, and as I watched that, again, knowing what I know about this population, and seeing that, it was like, oh my gosh, we have to try it. So I brought her out, I had her teach my whole staff, and then I had her be in clinic with us for 2 days, and apply it to our kids with arthrogryposis, and we saw amazing things. I'm not gonna say it's the end all, but I'm saying it's a new tool. It's amazing. And the more you know, the more you know you don't know. But open your mind to things that maybe haven't been done. Okay, serial passing, achieving correction, maintaining correction with bracing, functional mobility. So I want these kids to be moving however I can help them get them moving. I don't want to just accept that they're going to be holding a pencil or something this way, because a lot of them have hands like this, right? So can we splint their hands? Can we splint them here? Can we get their elbows moving? I don't want to say this is the only way they'll ever move. In a lot of places they'll say, they'll find their own way to do it. Let them do it their own way. We disagree. Let us try to unlock them and then see what we can get functionally. If we can't, we can't. But you gotta try. You cannot tell a parent of a newborn, this is how they are. Let's figure out what we can do better. And I can tell you, these kids, they will surprise you so many times. I don't want to limit them by what I think they can do. And I will tell their parents, I don't know what we're going to get. I've seen some extremely severe cases, extremely severe, that would not even ever be able to sit up on their own. I've seen babies so deformed that their parents can't even hold them on their hip. They have to hold them like a little egg. And we're able to get better. I don't know what the ultimate outcome is, but I know that a baby that's got a bottom and the legs up by the shoulders, that's not functional. That's not functional to sit in a wheelchair. It's not functional to roll and play on the floor. It's not functional. So, all right, let's go on. And some of them are going to walk, and some of them are going to do relatively normal things, but not all. But let's see what we can get. Okay, serial casting. I keep going on tangents. Manipulation and stretching with the application of well-molded plaster casts, not fiberglass, plaster, because you can mold those casts exactly how you want them. If I put a fiberglass cast on, I cannot mold it well enough to hold the foot or the knee exactly how I want it. And the casts are in place from 3 to 7 days. And really, it's more like 4 to 5. Sometimes with these kids, if they have to travel back and forth, like I have families that come to me from Miami or from Orlando or from, and then further than that, they usually come and move to the area for a period of time during the casting, like 4 to 6 weeks. But if they're driving a long distance, we will try it at a 7-day interval. But if it's not working and they're getting stiffer, we go to 5. Anyhow, manipulation and stretching in between each cast. And we continue the casting as long as they're progressing. Once they plateau or reach maximal correction, we then splint them to maintain the correction. Now, There may be a soft tissue release at one point in time if it's a small procedure. They don't do huge procedures on these kids until they're about 18 months, but they are finding, certainly the tenotomy is something that's totally able to do, and these kids will undergo that when they're little. Okay, so let's talk about, here's a case study, results of a little girl with a newborn with arthrogryposis. She had left hip dysplasia, bilateral knee extension contractures, so her knees were hyperextended. She had a Pavlik harness. Have you guys heard of that? No? Okay, it's a little harness that holds their hips in abduction. So when they're tight into adduction, their hips, their femoral heads tend to go out of socket. So you want to bring them into abduction. So it helps put the femoral head in socket. Okay. So sometimes they'll use like the double diaper method if it's just really mild, and sometimes they'll use the Pavlik harness or other types of harnesses. Sometimes they'll use serial casting for the hips as well. That's usually done in the OR. But anyhow, so this child had the Pavlik harness. She was referred to us for serial casting. She received 5 weekly casts. Now, this is a case that we did in the earlier days. So we didn't know as much as we know now. And so we were doing her weekly. She did fine, but now she would get twice weekly casting, and she probably wouldn't have needed 5 weeks. She probably would have needed 3 weeks because you go faster when you're doing it twice a week. Anyhow, but she did great. She achieved 90 degrees of bilateral knee flexion, and the family moved out of the area. But this was a little girl at birth. Okay, and her hips were up by, her feet were up by her head. So she was stuck in a Frank breech position at birth. I also got to tell you a little story. My granddaughter was stuck in a Frank breech position as well. And that is terrifying if you know everything that can go wrong. So I was actually casting a little child like this when I found out that she'd been stuck for 3 months, and I was terrified. She's fine. But sometimes working in pediatrics is really scary. Anyhow, so we casted her, and she then was able to move her leg through 0 to 90 on her own, and she did great. This is a child, this next one is a child that had bilateral vertical talus. He had a form of pterygium, which is a genetic form of arthrogryposis. His father also had it. They came to us from Israel. We knew that that was not going to be the only treatment. The early intervention was not going to be the end all, but again, you don't want to wait until they're done growing. I've heard that said a lot also. We'll wait until they're done growing and then we'll see what we can do. No, please don't do that. Please don't do that, because what happens over time as you grow?
Bones harden. The bones harden.
Yeah, the bones grow longer, and then the muscles are shorter because the bones are longer, right? So contractures become more set in stone as if you just wait. So this child arrived with us at 7 months of age. He already had a tracheostomy and he had a G-tube for feeding. He required suctioning 3 to 4 times per day. Hour. He had bilateral vertical talus, which is the exact opposite of clubfoot. Have any of you heard of vertical talus? Okay. With club, I have slides showing it in a minute, so just trust me, it's the exact opposite. So the treatment is the exact opposite, where you hold the talus and rotate the midfoot around for clubfoot deformity. You do it exactly the opposite for vertical talus deformity correction. He also had right hip dysplasia. He had knee flexion contractures. He was stuck at 90 degrees, and he had pterygium. Anybody heard of pterygium?